do our COPD lecture. And then tomorrow we will close out the block with asthma. So today, real quick, we're just going to summarize the lectures we did last night. I'll do the quiz questions real quick for those two lectures just because they're short, and then we'll jump into COPD. So last night we went over two lectures. One was the other airway disorders, so talking airway here, not COPD, not asthma. So these are the other ones. It was pants heavy. So one of our first lectures where we're actually looking at the actual disease topics that pants is going to be looking at. And again, most of these you're going to learn again in peds. Get familiar with them now, and then we'll be able to reinforce them later. First one was the foreign body. Talked about different ways that patients can present depending on where the obstruction is, if there is an obstruction. Again, sometimes it's not the type of object that can actually fully obstruct, and so it'll sit kind of sideways in there. Coins are classic for this, non-round objects. Patients that come in that you should be concerned about are ones that come in with this classic triad of coughing. You can hear air trying to move, so it's causing some like a musical instrument where you're hearing sounds different coming out. It's not that normal breathing that you hear in auscultation, and you may hear it audibly. And if there is a full obstruction, when you're listening down in the lungs, you may hear diminished breath sounds on the side that's obstructed. Upper airway is most life-threatening, so that's why we really get nervous about this in kids, because our airways are so tiny. And just remember, if you have a child or an adult and they come in and they say respiratory and you say, let me put eyes on them, and they're tripoding, leaning forward, drooling, they don't look comfortable, they look like they're working to breathe hard, don't waste your time auscultating them. You want to perform emergency interventions. And those are typically our back blows, our chest compressions, our Heimlich, and then you want to be having someone call if you are not in an emergency room. I hate to get to the 5 minutes into a code and realize I forgot to tell someone to call 911. So when it's witnessed, when you have a higher suspicion, you're always, it's never a wrong answer to get chest x-rays on all these patients, even if you have a low suspicion. If you have a higher suspicion and you don't see it on x-ray, it's not a bad idea to move over to CT, especially if it's been witnessed. Or if you notice anything on exam that makes you think that there's something in that airway, a sound or a symptom, if they're still coughing, if they look uncomfortable. Adding that CT is going to pick up some of that non-radiopaque material. And again, we don't want to leave it in there if it's there, and then you follow up with these guys pretty closely. If we leave it there, and it's organic especially, we're looking at a possible infection over time. So the middle respiratory stuff we're talking about is the epiglottitis, so we're down kind of in the throat area. This is our classic Hib. We now vaccinate for this, so we don't see it as often. So as opposed to the foreign body aspiration, this is a little drooling, a little distressed, but these kids are going to be sick. This is caused by an infection. So they will be sick, they will have fevers, they will not look well. And then the thumbprint sign, that's the radiologic imaging on that lat that we associate with this. And then the keys to treatment here are get them to some definitive care if they're in an outpatient clinic, and just make sure that we are not doing anything to instigate that area, because it can close up pretty fast. And kids are classic for kind of panicking. You release all that cortisol, and things kind of start happening that we don't want to happen. We want everything to be nice and calm. The croup, goes with the parainfluenza virus. This was our barking cough. I don't know if anyone's ever had kids with the croup, but you watch Terms of Endearment. It's an old movie, but there's a scene in there where she's in the bathroom trying to get her kid calmed down in that nice moist air, and it just sounds like I don't want to do it, but it sounds like a barking seal. You can hear stridor as well. Again, it's up in that upper airway, so it's a little bit more audible versus those wheezes that we kind of have to get down into the auscultation to hear. And then because it is associated around that larynx area, you may also see some hoarseness. So they're when they talk. So parents will usually come in day 2 when that barking cough starts. Real important to educate them that this progression of disease usually gets worse until around day 5. You can give them a single dose of steroids if you feel like the kids are sick or they have any additional risk factors. And then that steeple sign, that was that little peaked, when you're in that upper airway and you have inflammation, you have that little kind of peaked airway on x-ray. Not very common to get x-rays on these kids, unless you're ruling out, maybe you think that they also might have a pneumonia or something associated with it, but that is the x-ray finding that we associate with croup. The word association. Bronchiolitis, that was our kind of farther down into the bronchioles. Bronchioles are more vascular, so a lot of times we'll see these kids having a little bit of blood in their sputum, lots and lots and lots and lots and lots of mucus for RSV. We have outbreaks on this, so sometimes you'll see, hey, we got another RSV, and someone's on the phone with CDC letting them know, hey, you got to start sending these kids home when they're sick. It's usually self-limiting. Kids generally do well with this if they're otherwise healthy, so you really want to reassure the parents. There is a test that we can do. Usually we don't really start moving to that until we start to be concerned about an outbreak, and then we kind of want objective documentation that we're having cases of these and it's not, a missed clinical diagnosis. So we'll do that. We'll also do it if we want to reassure parents that we know what this disease is. We know it's respiratory syncytial virus. It is a self-limiting disease. You don't need to give you antibiotics. Everybody wants antibiotics. I think we're getting away from that a little bit, but it's still, I still get family members calling me, hey, can you call my husband in Z-Pack? Can you call so-and-so in Z-Pack? And I'm like, for what? So, yeah, because they're coughing. I'm like, give them some Flonase. And that usually works. All right, so that was 6. Let's do 9 real quick, and then we'll do quiz, and we'll switch to COPD. So this is 9. This was a pretty short lecture. So this was our sleep apnea lecture. Kind of out of order here how we taught them, but the first one up here is our obstructive. We tied this to the kind of overweight middle-aged man, but there are also many other patients that can have COPD, like our TBI patients, right? So there's other correlations that we can have with this. So if the patient's not an overweight middle-aged man, you don't automatically rule that out. That's just the most common person that's going to present with this condition. The 3 associations are this resistant hypertension. So you have patients come in. My favorite are the ones that their blood pressure's uncontrolled. We've got them on 2 different medications. And then you note that they have sleep apnea as well, severe, and then you ask them about their compliance. Oh, I can't wear it. It's a pain in the butt. So you try to encourage them. We're going to have to just keep upping your meds most likely if we don't get that sleep apnea under control. And I've seen it where once they start being compliant with that, we can actually get them down off their meds. So there is a real, based on data and based on my own anecdotal experience, this is one that we really want to encourage people to treat this. The daytime somnolence, the mortality side effects of this, we do see this. Daytime sleepiness, like we talked about, even compared to being under the influence, can sometimes be more dangerous. And then just, partner relationships, right? So loud snoring, apneic episodes, it can be really disruptive to people that share the same bed. All right, sleep study measures, we talked about the AHI. We define mild cases as 5 to 14 events per hour. And those are typically managing risk factors, losing weight, not doing sedatives at bedtime, treating your chronic sinusitis, things like that. And then that mandibular device is one that we when it's mild, we don't necessarily want to, spend the money and get someone started on a poorly compliant treatment. But sometimes we get there. But we usually start with that mandibular device if managing risk factors doesn't help. Moderate, of course, it depends. You're kind of in between, but once we get to severe, CPAP's kind of the gold standard. So we want that positive pressure, pushing the air in. We don't want to give them any additional oxygen because it will increase the duration of the apnea. But we want to be able to, when the body decides to stop ventilating and takes that little apneic pause, the CPAP will keep breathing for them, keep ventilating for them. Keeps their O2 up, and then all the side effects of that, they typically helps with the snoring, keeping that airway open with that positive pressure, and then they're less somnolent during the day. And then the obesity, hypoventilation, they also have sleep apnea. So this is kind of a subcategory of that. Diagnoses usually are made when we see a BMI over 30. And then they have daytime hypoventilation events. So this is a diagnosis of exclusion. That really the gold standard of this is a daytime ABG. And we demonstrate that PaCO2 is over 45. And then it's treated very similarly. The reason why we identify it separately is that there's a higher mortality. And that's where we talk about where it's going to be affecting that cardiopulmonary system. You're not circulating well enough. It can cause heart failure. We'll talk later about poor pulmonale, things like that. So this is why we pull it out and identify it separately. Any questions on that? All right. So 2 quick. I hope these are good. Sometimes I write these quizzes and, okay, so these are, again, where we're going to kind of start. We're talking pants here. So these are ones I pulled off one of your pants practice sites. So do we remember what the definitive diagnosis for this was? It's so it's the hello. This is not on. Yeah, so it's the sweat test. Now you're gonna genetic testing is part of it, but to make the clinical diagnosis, because they can have the mutation but not necessarily have cystic fibrosis. So it's that elevated sweat chloride test done twice on 2 different days. So that's how we diagnose this. The other things just help us have a higher clinical suspicion. So the hints here are really, really bad runny nose, bilateral wheezing, so we're not getting the barking cough, right? So what's the most common reason? And those 2 clues are leading you towards bronchiolitis. So what's the virus that we associate with bronchiolitis?
RSV.
Yeah. 5-year-old urgent care, difficulty breathing, low-grade fever. You'll get to the clues in the middle of the stem. So without wheezing, we're thinking it's not down in the bronchioles or the smaller airways, right? It's more up here. Barking cough, that's your big clue. So do we remember which virus goes with that?
Parainfluenza virus.
All right, good. This is the last one. So partial obstruction up in the tracheal area. So we're going to cause some changes to the mechanical flow of air. That's like an instrument, makes a sound. So which one's this one?
Strider.
Strider. So the other ones, wheezing, we're thinking lower down. Inability to cough, they're going to be coughing like crazy. Absent breath sounds. It's partially lodged, so you're still going to be moving air. And then cyanosis, that's usually when there's a complete obstruction. Oh, sorry, one more. Which of the following pathogens is the most common cause of epiglottitis? Easy question. The one we vaccinate for now, so we see it less.
Hip.
Hib, the hib, yep. All right. Sorry, I should have put this all in one slide. Last, this is just a couple. All right. So we're talking about obesity hypoventilation syndrome. So which one of these is not? So is A part of the criteria? Yep. Is B part of the criteria? Yep. Is C part of the criteria? So if someone's pulse ox is less than 90, do we consider that part of the diagnosis? Having apnea, right? Yeah. Sleep disordered breathing, that's part of it. And then since it's a diagnosis of exclusion, not having any other disorders that cause it. So it's C. So the point of this here is that, you know, someone comes in, they're obese, they're hypoxic, you still need to do a little work in working them up. You can't automatically call it obesity hypoventilation. Do you remember what our moderate cutoff was?
Uh, 15 to 20.
Oh yeah, it's not cutoff point, it's a range. Yep, so it's B. So 0 to 4 is my favorite answer. And then over, yeah, that's actually my favorite answer. All right. So this one's kind of a silly question, but which one don't we recommend for sleep apnea? Let's see. And which one of those is the gold standard for moderate severe? CPAP. Positive airway pressure. Now in like an ICU, you're not going to necessarily use a CPAP, you're going to use other PAPs. Lots of fancy PAPs. But CPAP for outpatient treatment. All right, big breath. So that was 6 and 9. We're going to jump into 8 today and then lecture 7 tomorrow. And then then you guys can fully focus on MPH and endo. Instead of just partially focused. All right. We all did it. All right. Well, a little ahead of myself here. What do you guys have after this? GI? Okay. I'm not going to jinx us, but okay. Oh, and then we have ClinCore at 1. Never mind. All right. Dang it. Did it again. All right, so this is certainly going to be, you know, we're certainly going to have a pants sign on here, and then tomorrow an asthma as well. So these are both ones that are covered. When we talk, when we talk about just pure obstructive diseases, airway obstruction, there are several conditions that fall into this. Asthma being one of them. We talked about those are the main two, but there's other restrictive airway diseases or obstructive airway diseases. COPD, again, we call it chronic because these patients typically have a history of smoking most commonly, and we'll talk about other reasons people can get this where it's not associated, but it's usually a older person diagnosis. There are some genetic conditions that someone can have where they can present with this earlier, and we'll talk about that one. But in general, COPD is going to be more of your internal medicine, or if you're in a smaller outpatient clinic, you may have to treat some patients with COPD. So, third leading cause of death worldwide. It's not necessarily the most common, and in fact, we're probably going to see less of it over time because people have gotten away from the cigarettes. More, of course, a lot of them went to vaping, but that chronic cigarette use. And again, when we talked about bronchitis, we talked about how we're more concerned about some bacterial components to that. And so a lot of these people, they develop this chronic bronchitis, and then over time, by introducing all of that toxic material into their lungs, they develop infections, they produce more mucus in response to that, and over time, this kind of sets in and becomes a chronic condition, especially if they continue to smoke. The way that we define it, we call it daily productive cough. I wouldn't worry about memorizing that, but this is how we define it. Daily productive cough for more than 3 months at a time in a 2-year period. Now, the first time somebody develops the symptoms, and you think it's COPD, and they look and they walk and they talk, don't say, okay, we have to wait till you have this for 2 years before we start treating you. You're going to want to send them for spirometry earlier. But this is how we define it. Emphysema, this is our other chronic obstructive disease, and this is the permanent, and we talked about this one a little bit, and I did finally fix my dang slide, right? And then when I fixed it, I actually did the same thing again, so something in my brain keeps telling me to think about backwards. But emphysema is when you have less resistance, you kind of destroy all those little alveoli in that lung tissue over time. And we don't really understand why people develop one over the other, because the pathophysiology of it is very similar. And a lot of times patients will have a combination of both. Either way, their lungs aren't functioning well and they need to quit smoking in most cases. Okay, I wrote that down, yep. All right, so smoking, get that in your head. I remember early on, I think our first lecture, I showed you the nicotine staining. That was my classic learning COPD patient, was that old man that used to yell at me. So that's kind of what you want to kind of put in your head. Again, if they don't have nicotine staining, they don't have a big white beard, doesn't mean you don't send them for COPD, but that's kind of your classic patient that you want to think about when you're starting to learn this. So most people that we diagnose with COPD have a smoking history. Unfortunately, most of the other ones, except for our kind of rare genetic association, will have some history of exposure to secondhand smoke or something occupational. And then that last one, this one we'll talk about later, that's a more rare one, but patients can be born with this alpha-1 trypsin deficiency, and this can also cause COPD. And we'll talk about that and why. All right, so smoking. I hate to admit this, everyone, but I smoked for a long time. So when I read these, I think I was studying in med school, reading all these books and like, you know, drinking my Diet Coke and taking smoke breaks, and I finally quit though. Mostly for just vanity reasons, but you know, I'm happy I did it. So, and we'll talk about a slide later when we talk about getting people to quit smoking. That's a whole art in itself. And I think having smoked, it kind of makes it a little easier for me to kind of have empathy for people and get their buy-in. But getting people to smoke, to quit smoking, can actually, we'll show you what that looks like. It can actually reverse their symptoms. It's just unfortunately very hard to get a lot of these people to smoke that have been smoking forever. But we'll show you that, and I've used this chart we'll go over with patients, and I really think it helps to get buy-in when I'm trying to get them to quit. So we talked about, you know, lots and lots of mucus. These guys are just hacking. They're coughing up mucus constantly. And this is again in response to that kind of constant toxic material, and the body's going to respond. If you keep putting in an agent that's causing the body to have to respond, immunology, so it's trying to protect itself from that toxin, and so it's going to do the things the body does. It's going to produce mucus. That's the lungs, especially the bronchi's way to protect the body. So it's going to just keep doing this. But you know, I had a guy one time, he smoked 5 packs of cigarettes a day. And I'm like, wait, 5 a day? He's like, no, 5 packs. I'm like, what else do you do? Seriously, like just turtle lights them all day and just, it's constantly smoke. That's like 100 cigarettes a day. I couldn't believe it. But he was an old crusty old man. So, but you keep doing that all the time, and your body's just constantly producing this. And at some point, those goblet cells, they begin to hypertrophy. They're trying to keep up with that toxin. You also cause damage to the cilia. Cilia are just as important. They're trying to move all that stuff out. And so the mucus just sits in there. So these patients are just constantly hacking up nasty mucus. And then eventually, you know, it gets down to the actual tissue in the airway itself and causes some fibrosis. Just the same way, you know, when you cut your skin and it heals. You know, there's a little scar there, and the scar is fibrosis. Keloid's a little more a significant scarring, but when you cause damage over and over again to tissue in your body, you're going to develop scarring, and that's kind of a different way of thinking of fibrosis. And it really impacts ligaments. Same thing. You know, you sprain an ankle, you get fibrosis in there, and it just changes the function of the organ. So in the actual alveoli, smoking leads to how it leads to emphysema, and that's just direct tissue destruction. So these alveoli are like, think of the orchid plant. You know, they're the really, really delicate flowers at the end. And so the stems, the leaves, you know, they can still be green, they can still be working, but the flower, you know, is usually they're going to be the first part to die. It's the most delicate. It's at the distal end, you know. And so you destroy that, and these alveoli become enlarged, and they really don't function anymore, so they end up just trapping air. So they're not opening and closing to move that air. So A, they're not oxygenating the way they're supposed to, and B, they're creating dead space in there, where that residual volume, or the reserve volume, what do they call it again? RV? Is it residual? No, it's not residual. Anyway, I forget right now, but that RV, when we talk about our PFTs, is going to go way up. And so your FVC is going to go down. So increased neutrophil activity. Obviously, that's the body's response. And then we just keep smoking cigarettes over and over and over again, and it's like a cycle. So this was that chart I was talking about. I think it's very accurate, and I think it's very helpful. And so even if you have people that have been smoking, and you're seeing in the age 50, you know, you can have a significant impact on reducing their disability if you get them to quit, even around, you know, even if they've been smoking for 20 years and they're 52, you know, I've used this chart to say, hey, you know, it can actually make a difference. If you keep smoking, right around 65, it's going to, even if you quit, it's going to be really hard to keep yourself out of that disability range. But if we get people, especially like, our older service members, to quit, around 45, 50, you really got to hit them and say, hey, this is where we can really make a difference and keep you out of that disability range. And this is good data. So use this concept when you're trying to get people to smoke. Pictures work really well for patients, especially if they believe them. All right, so here's some, this is kind of going to be a reiteration, but we talked about, typically we start seeing symptoms around 40 to 50 because typically people start smoking in their late teens, early 20s. So they'll come in and they'll just talk about this cough, chronic cough. And this is one that is certainly going to be in our chronic cough differential, is COPD. So chronic cough, coming in, lots of sputum, positive history of tobacco, so all your fun history and physical that you do. And this is another kind of one where, they may say, I've been coughing, they come in at day 5, you're calling it an acute cough. But when you ask a few more questions and you say, hey, is this something that you have ever had before? Oh yeah, I get this all the time, or I'll get it, I just never come in before. Or I saw another doctor who just kept giving me antihistamines and Flonase and telling me to take over-the-counter cough medicine. But when you put that all together, when you get that really good history and you see, hey man, this has been going on for a while, and he seems to have, or she seems to have episodes of this, then your brain starts to kind of push COP, and then you would call it a chronic cough at that point, and then you're pushing that COPD up the list on your differential. And again, these exacerbations, typically, because you're not moving that mucus, that stuff's just sitting there, the cilia aren't moving, your defense system's kind of down, infections love to set up in there. So when we talk about COPD exacerbations, we'll talk about how to treat them, and they almost always include antibiotics, because these guys love to grow bacteria in their lungs. And of course, it's going to make your shortness of breath worse, it's going to make your cough worse, it's going to make everything worse. And then later on, when someone's in a later stage, closer to hitting the bottom of that disability and maybe drifting into that mortality section, it actually becomes less, because the lungs just really get pooped out. They can't cough as much. Their lungs basically get tired. They're mucked up with mucus. They're not taking deep breaths because they don't have the airspace anymore, and it just becomes kind of like their lungs start to poop out a little bit. And then as that happens, of course, their shortness of breath goes way up. So they start to complain less of the cough and more of, if I get up from my chair and I walk to my kitchen, I have to sit down. And that's when that, severe dyspnea, and this is kind of what we'll see at the end of COPD. And then, like we said, a lot of these people, especially in the late stage, they're going to have a combination of both. So, it kind of starts here. This is where the smoke starts. It starts causing changes here. And then over time, we start to see more of the symptoms associated with the effect of smoking down here on the alveoli, which is what we call emphysema. All right, so this is something, I've seen this concept, this is how I learned COPD and emphysema, so I've seen these words used and this concept used on some of the PANS questions, so you should know it. COPD is the blue bloater. He's the big dude or woman, the big person, that's got a big barrel chest, he's coughing a lot, he's cyanotic. Maybe we actually set hypoxia ranges different for COPDers. 92 and above, we usually go down more to 88 with our chronic COPDers, because that's where they really live. So they're always kind of mildly hypoxemic. They always have kind of a bluish tone to them when they get in these later stages, especially if they keep smoking. And these are, unlike our asthmatics, this is not one of those hyper-responsive where all of a sudden they'll just snap shut. It's more of just like an indolent, progressive, over time. They will definitely sense it when they're in an exacerbation, i.e. they've got an infection or something they got exposed to. But usually this is not one where we're thinking like with our asthmatics where we're getting them to the ER and giving them nebs and things like that. We talked about this already, heavy cough, chronic, lots of sputum. And then, the daily cough for three or more months at a time, having been going on for 2 consecutive years. So again, they're chronically hypoxic, so sometimes you can see kind of just, they look a little gray. You'll see that in cardiovascular disease as well, where people just look a little gray. And then they're dyspneic. Definitely lots of coughing fits, and just generally overall short of breath. So it's bronchi, and bronchioles that are mostly affected in this disease. So we're gonna have our bronchi. So that's that kind of wider gauge instrument, right? So we're hearing that, that rough. It sounds like, like someone's running their fingers over a rough grate. It's just very, like a rough sound. And then sometimes we can hear wheezing as well when it's affecting the smaller airway, the bronchioles. Peripheral edema can be associated with this. So that constant coughing, you're not circulating normally. So the body needs kind of like this nice place, this nice pressure to live in, because it's all associated. Remember, we talked about the gradient of pressure. So for air to move, you have to drop that diaphragm, create a pressure difference. For oxygen to diffuse, you also need that gradient. It's very important. Again, that's where our pH and ABGs come in. And so this constant coughing doesn't allow that to be optimal, and so you do see some backup. And then we talked about the lung infections, very, very common, unfortunately. And more than likely, we call them blue bloaters because typically these patients have a larger body habitus, but not all. All right, emphysema, these are our pink puffers. And they do very shallow breathing. They're usually not very overweight, usually very thin, usually have a big chest. And unfortunately, like we talked about that gradient, this is, we call it kind of like pursed lip breathing. They have tissue destroyed, and so there's no pressure kind of pushing back to help that ventilation. And so they'll actually just be able to take little sips of breath. A lot of them will purse lip to try to breathe out. They're trying to create that pressure difference to move air because that tissue is destroyed. So they're losing that pressure gradient. And then the barrel chest, not always evident, but this is just something that we associate. So just widened out chest space, not using tissue. And the reason why they're thin is because they're constantly trying to use their accessory muscles and their diaphragm, so their resting metabolic rate's usually pretty high, just the work of breathing. So they're typically thin. So here, this is our little picture, help us understand. Our cougher, lots of mucus, usually with packed cigarettes, and then our emphysema patient on the right, usually a lot older, thin, and again, the one on the left can progress to the guy on the right, or you can present just with the emphysema. But usually you have a little combination of both. Unless, like when we get to talk about the genetic stuff, because those will affect usually one area. So they're constantly trying to work to breathe. The emphysema patients, they're thinner because their work of breathing. They're a little redder because they're constantly burning calories, very thin. And then our exam, you know, the COPDers, you'll hear all that mucus and nasty stuff in the airway. Emphysemas are a little bit more quiet. So we talk about diagnosing this. Chest x-rays really aren't helpful. They're not really very specific findings, like when we're looking for a pneumonia or when we're looking for a foreign body or anything like that, something more radiopaque, a disease process that presents more clearly on a chest x-ray. It's probably going to be part of their workup at some point, especially during exacerbations when we're looking for pneumonias. So if you have a patient with COPD or it's a new diagnosis, it's not a bad thing to shoot a chest x-ray, rule out other causes, and then just establish a baseline. It's the same reason we do EKGs in the military for our PHAs. We want to establish a baseline so that when the next person sees them, they can go back and look and see what was normal or where they were a year ago. It's comparing, and we'll talk about that when we talk about nodules, how important it is to be able to compare to previous imaging. Yeah, so with chronic bronchitis, you know, it's pretty nonspecific. Sometimes you'll have these peribronchial, perivascular markings. So when we talked about that kind of flow being pushed back, sometimes you can see that congestion around where the vasculature is and where the bronchi are. Sometimes, especially in later disease, you can see it more. Later disease, you can also see a little bit of cardiomegaly when we talk about that pressure kind of being pushed back on the heart. But again, for chronic bronchitis, it's not very specific. The emphysema, similar. We'll show you what pictures of these. Very similar. I think in late stage, you have this classic kind of real widened out space in the chest cavity. The heart looks kind of small compared to it. Diaphragms are usually flattened because they're being, you know, overworked to try to, in a chronic way, to try to pull that air in and push it out. So this is our emphysema we were just talking about. So you look at normally, and then on the right, this is emphysema. You see that chest space pushed out. And then by contrast, the heart silhouette looks tiny in that big cavity. So our ABGs, you know, typically this isn't part of outpatient workup, but when they're inpatient, a lot of times people will get ABGs to check, again, go back to ABGs, we want to check severity, and then if we do any treatments, we want to use the ABGs to see if the treatments are working. So earlier on in the disease, you know, when they're chronic bronchitis, the COPD patients, they are not ventilating effectively, they're not blowing off that CO2, and so they will be typically acidotic. Because of the chronicity, we usually see that the kidneys have had time to compensate. So we typically will see in chronic bronchitis respiratory acidosis with compensation. And then later on, when the disease becomes more progressive, the kidneys, you know, are doing all they can. It gets down into the actual lung tissue. We see some failing compensation. And that partially has to do with the fact that we've destroyed that tissue. Patients live in a hypoxic environment, and that's not good for any organ in our body. Sputum cultures, we don't typically get these, but when we treat exacerbations and patients don't improve with the antibiotics, this is a time where we would get that collection of that sputum to see if there was maybe another, an agent. And we'll show you kind of what all those different agents are. And then ECG, again, it's not a bad idea for any patient with chronic disease to get at least a baseline EKG, because when they come in with chest pain the next time, it's really nice to compare the EKGs. And this is, again, why we started doing them in the military, because in Desert Storm, we brought all these reservists up, and they were not maybe in the greatest shape. And so they would go out to wherever, and they would complain of chest pain. And when they would get seen, they would see axis deviation or a bundle branch. And so especially with the bundle branch blocks, if it's new, that's significant. If it's not, it's not. And so that's why we started doing these baseline EKGs at 40. It wasn't really because we were screening for anything. Dive physicals are different, but we're not screening for everything. We're just establishing a baseline to be used later by the clinicians. For example, when a patient comes in and now has symptoms. It's real. So we're evacing all these people, but if the EKG, if the left bundle branch wasn't new, we didn't have to evac them. We were evacing a ton of patients with chest pain. So then they started that. So it never made sense to me why we get asymptomatic EKGs, but after years of research, I finally figured out why. In later stage, we're talking about that chronic hypertension. We'll talk about that cor pulmonale. And really, it's just that right axis deviation is typically what we'll associate with the COPD in later stages. So this is kind of another review, just to differentiate the two, kind of like that picture I showed you. Bronchiolitis, big blue bloater. Dyspnea is not really prominent unless they're in an exacerbation. Tons of heavy, copious coughing, sputum, common to get infections because, again, that whole defense system in your airway is being overworked to the point that it's letting the body be more susceptible to some nasty bug getting down in there and just being, like rubbing his butt and all that mucus, and the cilia are gone and it's not getting pushed out, and it sets up very easily. So the airway resistance, the obstruction is going to be increased. So we're going to see that FEV1, FVC go down. And the recoil is typically normal early on for COPD. Vasculature can be prominent in later COPD as well as signs of cardiomegaly, which then lead into our EKG right axis deviation. As opposed to emphysema, we call those pink puffers. They're more prominent dyspneic. They look like they're trying to pull air into their body and force it out. And it's always drove me nuts to walk out to like the smoking area and then, see somebody smoking and then, not me at the time, but then to walk in and be talking to them and watching them, purse their lips to get air out. And you just know that they're destroying that tissue in there every time they go out and smoke. And it'll progress as long as they keep smoking. Because, when they said pulmonology, it was like, man, pulmonology is like my worst because that's like my scariest, and I think, people that worked in the ICU during COVID, watching people not be able to breathe is like one of the hardest things. I can watch them bleed out, I can watch them poop and pee and have babies and all day, but when I see someone that's struggling to breathe, it's giving me goosebumps right now. It gets you going. So not as much cough, not as much sputum, not as much, right? But not everybody reads the book. So if they are saying that they, anyway, just get them to quit smoking, that's the point. Elastic recoil down, we talked about that. And then you're going to see more of a hyperinflation and a smaller heart respective to that chest cavity. All right, so go back a couple lectures to our wonderful Blackboard lecture. Or Blue Box lecture on PFT. So we'll chat on this real quick. This is where we'll take that slide that we're going to give you for the test, and I'll kind of go into a little more detail about how to use it for COPD specifically. So early on, let's see what time it is. 17. We'll do this section, take a little break. All right, so early on, when people are first diagnosed with COPD, sometimes we don't see a lot of changes. Again, this is a progressive disease, and so if they keep smoking or they keep, exposing themselves to the things that are kind of developing this process, we'll see these changes over time. So early on, we may not see much. Kind of closer down to where they're, established patients, they've been diagnosed with it, probably continuing to smoke, or maybe not, we'll start to see that FEV1 go down a little bit. Meaning that mucus and that potentially kind of fibrosis in that airway is now starting to cause airway obstruction. And we see that in the form of the dynamic test of forcing that air out over 1 second. We measure that and we say it's decreased because the air can't, you're trying to blow through a straw and the air cannot go out the way it normally goes out in terms of flow. So decreased FEV1 and then of course the ratio. So we talked about the lower limit of normal and we talked about how we use the lower limit of normal to establish the ratio as normal or decreased. In COPD, they typically set that at 0.7. Now this will, at least in all the examples I give, 99% of the time correlate with being lower than the lower limit of normal. So we'll probably never see a case where it's below, the FEV1, FVC is below the lower limit of normal, but above 0.7. At least I won't give you any examples. But two different schools of thought, one internal medicine, one peds and allergy, they just define it differently. And it has to do with the population. And it has to do sometimes with this is how we've always done it. But for COPD, that lower limit of normal is replaced by just this one value, less than 0.7. And that's how you say, that's how you define it. And then later on, we start to see more of a mixed pattern. So our FVC starts going down, and then our total lung capacity. Do we know why? Why in later disease, COPD, in later disease, we start to see more of a mixed pattern?
Destroying the alveoli.
Yep. Perfect. So we know that they're progressing into more emphysema. All right, read the bottom first. So this is one of the maddening things about teaching COPD, is we talk about this GOLD, and this is something we've used since the beginning of time. So this has stayed the same. However, we don't use it to treat. So now, AstraZeneca and all these companies, they come up with these new management guidelines. And so we're not going to use the GOLD staging to direct our treatment. It's just to communicate severity. So a little frustrating. This chart will be on that slide I give you on your desk, so you don't have to memorize these numbers in any way, shape, or form. But GOLD staging is just a common language that we use in medicine when we're talking about this disease. And it's based off the post-bronchodilator FEV1. And we'll do a practice one after this to kind of solidify it. So this is GOLD staging. And all you need to know about it is that it exists, and that when somebody says GOLD, you understand that this is just to be able to talk severity when you're communicating with another clinician. All right, so that's the sheet you're going to get. So this is going to be our little example. So we're going to start up, and the first question we want to ask is obstructive or restrictive. So we're going to start with our FVC. We're going to look at our lower limit of normal, and we're going to compare that to the patient. So is the FVC normal or decreased? Normal. So not restrictive. Then we go to the FVV-FVC ratio. We look at the lower limit of normal. Actually, we don't. We just look at the patient. Is it below 70? Yeah. And that's, I've never seen a PFT where the lower limit is below the lower limit of normal but above 70. So I don't know if there's some patient out there It's because these PFTs are based off height, weight, age, you know, so when we're talking about asthma, it's a younger population, it's easier just to apply that straight number because we're talking about typically an older population. And so more of a homogeneous patient population. So setting the 0.7 is sufficient. So we've decided it's obstructive, right? Next question is it reversible? So, sorry. So now we come to our FEV1. So we've given them this bronchodilator here. We come over our FEV1. We look at our change. So is that above 12%? I mean, that's not what I meant to ask. Is it reversible? No, okay. So we're talking about obstructive, non-reversible. So we come down to our little chart here. I suck at this thing. This is like my driving. It wants to, oh, there it is. Okay, so we come down here, obstructive. Just ignore this. This is another one of those things where spirometrists want their own severity rating, right? And so I would not spend any time worrying about this other than to know that if you're dealing with a spirometrist, this is how, based off the PFTs only, they grade severity of obstruction. That's it. But it's nothing that we're ever really going to use clinically. So we come down here. So once we determine that it's obstructive, we come down here. We've already determined that it's non-reversible. And then we talk about COPD versus other disorders. When we call it COPD, again, this is post-bronchodilator, this is how we gold stage. So for this patient, what would be their gold stage? So say it again. So what we're looking at is we're looking at the FEV1 post-bronchodilator, which is here, which is here. So it's 57% of the predicted, and so 57% would fall into what category? Moderate, yep. I know I hate these, I'm sorry. I have to teach them to you. All right, but that's it. And again, gold staging, you're gonna have this chart. You just have to, and it's going to say post-bronchodilator FEV1. You just have to find it on that thing up there, which can be tricky, I understand. Sometimes I have trouble. But we're talking about the percentage of predicted FEV1 on post-bronchodilator. You come down here to the bottom, you find out which range that is, and then you can decide which stage it's in. Again, you're going to get this. You'll have something like this on the test. You just need to be able to find the information. All right, so the meds and management. Let's take a 10-minute break. This will be our last section. Our meds and management. And so we got 12 slides, so I want to take a deep breath. I'm going to stay focused, get through this. I will do the same thing. All right, so this is just a review of the meds that we use, how they work. On the next couple slides, we'll talk about actually using these medications for management. So this is a review, hopefully, from pharmacology. We're talking about our basic bronchodilators, right? Sympathetic, parasympathetic, bronchodilators, beta agonists. They are going to open up the airway. They are going to bronchodilate using that sympathetic nervous system. So they're going to push that airway open. They're beta agonists. Okay, so that makes sense to everybody. So we're opening up the airway. lot of recent studies, I know there's been a lot of changes in treatment and what we recommend and things like that. It has been noted that using these bronchodilators, especially the short-acting, they improve your symptoms. They don't necessarily help you long-term, and that makes sense because they're typically, either acute within minutes, hours to days, so they're not doing anything to kind of prevent those long-term changes. So this is just new things that we're kind of learning. We still use them though because they help with symptoms, and that's important too. When we're talking about quality of life, which especially in our older population, it becomes much more important to talk about quality of life versus preventing disease. Because at some point, it's why we stopped screening for cancers at some ages. It's why we don't have as strict rules on blood pressure in the geriatric. And we'll have a geriatric lecture on this, I think, your next semester. But why we kind of start not being so aggressive with treating things, and a lot of it has to do with just quality of life. Because all these medications that we give, people have to go to the pharmacy, people have to call them in, people have to wait in line, they have to make their appointments. I mean, it becomes kind of a pain in the butt to really deal with this. So, and I don't know if anybody has grandparents or has worked in kind of a long care facility, but it becomes a full-time job. So we try not to be as aggressive, but certainly even with opiates, things that we're not really worried so much about it, we're worried about making their quality of life good. So short-acting, these are albuterols, preventals, really fast action of onset, so that's good. Helps with symptoms immediately. Biggest concern here is that, people do get kind of shaky. The nervousness, I don't know if anyone's ever, I did have epi once in my leg, and woo, that was some good stuff. I felt like I could run around the post. But the inhalers will kind of cause a little shakiness, increase your heart rate. When we talk about people with a lot of cardiovascular disease, sometimes this isn't the greatest thing to use for them. We do not want them to increase their heart rate. Younger patients can tolerate this, but just ones that we use with caution. And we don't want them using it a lot. And when we talk about treatment, this is why we start long-acting preventive medications, because the goal is to only use this when we absolutely need it. So just often, the Combivents, the Duonebs. So Duoneb's classic, the ipratropium, albuterol, we combine them a lot. One of them's working on the parasympathetic, one of them's working on the sympathetic. So we're helping to open up the airway and decrease the inflammation and mucus production. Our long-acting beta agonists, these are our salmeterol, formoterols. Salmeterol, formoterols. A little bit slower, very often combined with inhaled corticosteroids. This is our Symbicort. And like asthma, we do see these long-acting beta agonists used alone. I won't get into the black box warning on LABAs for asthma. I've read several studies on it, on why we can't use a LABA alone in asthma. There is some data that proves that people have worse outcomes, but we'll talk about that a little more when we talk about asthma tomorrow. But they can use LABAs alone here. We've got our drying agents. These are our inhaled anticholinergics. These are our SAMAs and our LAMAs. So the short-acting ones, we already talked about that, the ipratropium. You can use it as needed. This is the one that I use a lot for that subacute post-infection tussive cough, right? So they're coughing. It's been about a month. They're still coughing. A lot of times I'll give them an ipratropium inhaler to use as needed, just to help kind of calm that airway down and to help decrease some of that mucus. Then we talk about your LAMAs, long-acting muscarinics. That's our tiotropium. And again, we're just introducing you back to these medications, and then we'll talk about how we use them in the management of COPD. Corticosteroids, that's another category. We've got our inhaled ones. Our Flovents, right? All of our new studies and our new guidelines saying that if you combine these, that you have fewer hospitalizations and exacerbations. So those are studies that are coming out, and they have actually changed some of the guidelines for how we treat obstructive airway disease, including asthma. And we're talking about not the mild, not the, occasional symptoms. We're talking more of the moderate, severe patients. And then we've got our oral steroids. And when we talk about asthma, we'll talk about using steroids more of in a short burst. Because again, asthma is reversible. It's episodic, not 3 months at a time, but a few days at a time. So short courses of oral steroids can be effective in asthma, which is more of an acute exacerbation. For our COPDers that are more chronic long-term, that inflammation's been set up a lot longer, we're typically going to use a longer taper of steroids for them. And we don't want to do this too early because, as you probably learned about oral steroids in pharmacology, long-term use of oral steroids is, man, it makes you feel great. So giving someone a Medrol dose pack, they're like, man, I felt great. And you're like, I know, but I sat through a malpractice case once of a guy who had mistakenly been not educated well enough to know, but he kept getting his oral corticosteroids renewed. I forget what it was for, but he had developed, a young guy in his 40s, avascular necrosis of both of his femurs. It was heartbreaking, and nobody could figure out why. And it was just a simple communication. It was a simple medrec. It was a simple, why are you still on these? That someone needed to do at some point, and they didn't. And so this guy ended up with in a wheelchair. It was heartbreaking. So be real cognizant with that. But they work, man. Whew, especially with the rheumatoid arthritis patients. And a shot at Kenalog, they're happy people. So you have to be judicious with it. Antibiotics, unlike asthma, we do frequently have to use these. So we have a higher risk of infection here because, again, it's chronic. It's like when you see that nice, beautiful flowing brook and the water's moving nicely and it looks nice and clear, and then next to it on the streets like this yucky, mucky pond of stagnant water just sitting there, and you can see all kinds of stuff growing in it. That's the same thing that happens in our body. UTIs, ear infections. That's why we tell you to drink a bunch of water with UTIs. We want that nice flowing river to kind of flush everything out. Otherwise, stuff starts to grow and it gets nasty. Okay, so this is FYI. I just want you guys to kind of I was teaching this up until last semester, I think. So in December 2023, we came up with new guidelines, right, on how we have to treat this. And it wasn't until a student in my last class told me, ma'am, pharmacology is not teaching this. And so I have, this is the old guidelines, and I'll just talk you through this real quick. Oh, I didn't figure out how to do the mouse, dang it. I had to do the mouse thing, but anyway, I'll talk you through this real quick. So so we're talking about we're talking about symptoms, right? We're talking about patient-reported symptoms, and so of course we develop a tool for that, right? We want to be able to be more standardized and more objective by asking a agreed upon set of questions that patients can answer, because then we can use that score clinically. And so we basically are asking patients questions, and then we're giving them a grade. And that's our MLRC grade. And that'll go into, and I think we also use this one in the new guidelines, so that'll go into that. And then we've got our CAT assessment. That's another one. Again, list of questions. And we use that information to put people into categories. The old categories down here on the bottom left, It used to be ABCD up until last December. So again, this is FYI, so don't study this or take notes. It used to be ABCD. And the way we put people into ABCD is based off of their symptoms and then what categories they were in based off of these assessments and scales. Times of amount of hospitalizations. So we put people in these ABCD, and then we came over here to the bottom right, and then we said, okay, based off of the group that you're in, based off of your symptoms, based off of your risk, how many hospitalizations you've had, how many exacerbations you've had, we put people into these ABCD groups. And then we looked in the little box and we said, okay, you should be on X. And that's how we did it up until this past year. Then AstraZeneca came out with a study showing that if you look in the boxes, right, if you start at A, that's just a bronchodilator by itself, right? A LABA or a LAMA. Then when you go to B, you see a lot of ors in there, right? LABA or LAMA, right? Then you go to C, and you see just LAMA. And then you go to B or D, and you see lots of ors in there, right? Then they start talking about combining them in group D, right? So that was a good thing. Maybe you want to use them together because guess what? We got new medications where the meds are together, which what do we say? Improves compliance. So that's a great study to say, you know, we've improved compliance with the medications. And they usually do. If someone can take a combined, we do that with heart blood pressure meds. If someone can take one pill instead of two, of course it's going to increase compliance. So this is what we used to do. So don't memorize this. Now, this is what we do now. And really what I did is I kind of took, on the bottom slide, I took the old guidelines and I just kind of put in where things were different. So instead of, you know, group D and C and D, now it's just group E. And now instead of LABA or LAMA, when we get to group B, which is our symptoms of, you know, where you're just starting to notice that when you do normal ADLs that you've been used to doing without any dyspnea, now you're starting to get that more with just normal walking. And now we see the plus sign, right? So if we go up to the top, we start with a bronchodilator in group A, and then once we get to group B, now we're saying use them together. Now we're saying use a combined medication. And again, when we're talking about how to group them, you look over to the left, we're talking about symptoms, and then risk factors. Risk factors and symptoms are how we're going to do asthma as well. That's how we gauge management. What kind of symptoms are you having, and what are your risk factors for exacerbation? And that, to us, weighs the pros and cons of giving people additional medications. Because with additional medications, what do we have? Additional cost, we have additional risk for side effects, we have additional risk for all kinds of things, compliance. And so all these new updated guidelines did is they basically said, and they say this in the study, if you can afford it, you should use the combined medication because it's better compliance. And they simplified it, which is a good thing. But what I want to point out with this, you know, we can learn, okay, so we've got a one or less, so we have a patient, he had one exacerbation, he's never been hospitalized in the last 12 months, you know, and he gets tired, but only really with strenuous exercise, but he has an established diagnosis of COPD. So we're just going to use a short-acting beta agonist or a long-acting beta agonist. So a bronchodilator, right? Now when we get to the second group, now we're saying use the combined medication. But you can also use them separately if the patient can't afford the new medication. So With all of these guidelines, we always have to remember that what if you can't afford the combined med and all you're working with is this new guideline, right? You can use the medication separately still, it's fine, they still work. It just doesn't make as much money for the company that's making the combined LABA-LAMA right now. So sorry for the sarcasm, but when stuff comes out, I get a little bit skeptical because again, we haven't had a mass rush of people dying. We've been relatively successful with treating this. When new stuff comes out, everybody kind of rushes and say, well, if I'm not using the LABA plus LAMA, like that, I have to use that, and you don't. This is just guidelines. And if you read the fine print, it says if they can afford it, and but if they're fine, on medication and they're taking a LABA and they're in group B and they're fine, you don't need to change that. Now, if they're not fine, obviously you can consider it. But if they're doing okay, you don't necessarily need to say, oh, the new guidelines said that you're supposed to be on a combined med, so we have to do a new drug request and we have to get you on this really, 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 really expensive medication. So just keep in mind, I like the fact that we got rid of a group. I love the fact that we simplified the way that we group these patients. That's fabulous. I'll take that all day long. But I just want you to keep in mind that when we talk about options for treatment, these are guidelines. And when we talk about asthma tomorrow, I'll show you 9 different guidelines. It'll blow your mind. But in this case, this is what we're going to go with here. We didn't really talk about the eosinophils too much in COPD. It's not something that I really focus on because at that point, they're usually being treated by specialists. But we do check eosinophils. That is part of the specialty workup for it when we get into these really, really, really hard to treat COPD patients. And in those cases, we do add an inhaled corticosteroid. Does anybody have any questions on this? Like I said, I like the fact that we have simplified the diagnosis part of it. To go from all of this to this, I like it. You ask a couple questions and you've successfully grouped them. Yeah. It's going to be not something that it's going to be much lower down. It's going to be much lower down. So when we start talking about specialty treatment, again, these are the guidelines, right? So, dang it, I don't think I have the old ones. So there used to be places where we would add them, but it's usually when they're very, very hard to treat patients, so much later on. So it's a medication that specialists would use, but when we talk about treating COPD at our level, typically they don't come into play till much later on. It's only if they fail this, and honestly, if you're a primary care person and you're treating COPD and you're not going to try to, this is why we have specialists. So in most cases, you're going to send them there. Then when they come back, you read the specialist note, and then you understand how they use the medication because it's constantly changing. Preference, study, socioeconomic status. A lot of people can't afford this. And you have to come up, military is, for all the complaints I have about it, man, it gives you a lot of freedom when you're talking about managing patients because I've worked on the outside and it's heartbreaking sometimes, I need an MRI and someone can't come up with $800 out of their pocket, and it's a true thing. So that's why I get a little frustrated when this stuff comes out because, when you talk about that's all you have on your recommendations, it kind of plays a game with someone's mind like I'm not doing the best thing for the patient if I don't give them that, and that's absolutely not true because the words underneath say if you can afford it because it improves compliance, and of course it does. It's a great argument. I just don't want you guys to feel locked into this. All right, so that was management. And that's what you're gonna have to know, at least for our test purposes. Okay, so now we're talking about exacerbations. This is when your patient, known COPD, and sometimes they present with an exacerbation and they haven't even been diagnosed yet because they live in a trailer and they haven't seen a doctor in 100 years, and somebody found them and brought them to the ER and they gave him a bunch of steroids and gave him a bunch of crap, and he just shows up in your clinic and it's like, yeah, I haven't seen a doctor in 30 years. But I just got sent out from the ER. And he's a train wreck. And he's like putting a cigarette out as he comes in. It's real. If you ever end up in Fort Huachuca, it's like half your patients. That and a lot of OPEs down there still, unfortunately. Okay. So these are people that usually will come in. They're known COPDers. This will be, unfortunately, if you do ER shifts, it'll be CHF exacerbations and COPD exacerbations, depending on where you're at. And it's basically people that have baseline disease, they got a cold, they got pneumonia, they got something, exposed to something, and it just exacerbated their symptoms to the point where they felt like they needed to go and seek emergent care. Or sometimes they'll wait and just show up in your clinic like my guy used to do. So definitely, these are patients that are coming in, they're above baseline, they're coughing more, lots more sputum, they're more short of breath. Most of these are because they get sick. Most of the time it's because they get some sort of virus or some sort of bacterial infection. Because again, we got that nasty muck, and you go in there and you're like, ugh, what's growing in here? Because it's stagnant. It's just sitting there in the lungs. So, seeing this a lot more, depending on where you are, more commonly. CHF exacerbations in the ER, we always saw after Easter, and I proposed that it was because everyone eats ham, and it's a bunch of salt. But we saw a lot more of the COPD exacerbations in the winter. And I can imagine ICU during COVID, it was probably a freaking nightmare to have a COPD patient come in with COVID. So probably just an absolute nightmare. So treatment of exacerbations, typically, this is where your SAMA actually will come in. There it is. There's where your SAMA comes in. So if they're not already on a short-acting, you're going to want to give them that. So I don't typically have adults do an EBS, but this is where you would consider introducing the short-acting beta agonist and the muscarinic antagonist. So give them a ipratropium plus a bronchodilator like albuterol if they're not already on them. Now we don't want them just huffing and puffing on those the whole time, so we additionally will give them antibiotics. Most of the time when I've treated COPD exacerbations, we have sent patients out on antibiotics. Again, same thing with the bronchitis. I never treat bronchitis with antibiotics, but I think about it when they smoke because it just sets the airway up for more gunk. Oral steroids, again, we talked about it. You can give a burst sometimes, depending on the patient, but more than likely you're going to put them on a taper dose. And again, kind of like with that bronchiectasis, giving them we want them to cough that up. It's like when we do chest physiotherapy, we want to get that gunk out of there. They've already got a poor, they've already got obstructive disease in there. We want them to be able to cough that stuff out, and it can get pretty nasty. So you probably do want to give them maybe an NSAID because their chest wall is going to be hating you. And up here too, we talked about other triggers. It's not always viruses. It's not always pollutants and things like that. Sometimes we can cause this with other cardiopulmonary disease, but not anything that you need to memorize or know. It's more than likely going to be some sort of virus or bacteria. Oh, sorry about that. Okay. So this is our COPD exacerbation bug list. And this is one that you'll need to, I guess the stuff that I make bright red and bright blue are usually the things that I want you to be able to know, because I've seen these as questions on my tests and other tests. So for uncomplicated exacerbation, and this is how we define it as this. So this is where we start as clinicians. And we get to a certain point, and then we ask ourselves, is this right? Is there a reason I shouldn't be giving this? Is there something else I need to consider? Are we too close to the line? Do I need to ask someone? Have they already been on one of these medications and they're coming back and they're still not getting better? So, keep in mind that these are the rules. This is how you kind of memorize the information, but patients, you treat the patient. Uncomplicated, again, less than 4. They're otherwise kind of healthy. You don't need to be too concerned with the actual FEV. It's not something I'm going to give you on a test, but it is part of the way that we make this clinical decision. But less than 4 exacerbations per year without any comorbid illnesses, i.e., CHF, sarcoidosis of the lung. So they just kind of have COPD and not a lot else. Hypertension is not really a comorbid, so if they're hypertensive as well, I wouldn't really consider that to be a comorbidity. But in these cases, you're going to want to give them a macrolide. Other option would be a cephalosporin. And then our third option is my favorite antibiotic. If I could have one antibiotic, I would take Doxy. I love Doxy. And not so much for my gram negatives, but I love doxycycline. So those are the 3 we'd use if we call them uncomplicated. Again, this is defined as less than 4 exacerbations a year without comorbidities. And then when we talk about a complicated, and this kind of helps you understand, the types of patients. Someone's older with more than 4 exacerbations a year. Bugs are pretty much the same. And it's really interesting, I try to, sometimes when I read these, I'm like, how did they come up with this? Was it a study? Did they look at populations? And a lot of times they come up with it just by kind of, because we're never going to be 100% in medicine, but they just kind of look and say, okay, what is it about these people? What is it about this population that we need to start worrying about some of our drug resistant? Well, it's because if you have more than 4 exacerbations, you've gotten a lot of antibiotics, so that's a concern. And then secondly, when you're over 65, again, with those exacerbations usually means you go into a hospital. So that's why we kind of start to look at populations. And again, we're talking about a bell curve, but this is really how we come up with these rules. Because there has to be a way to kind of teach it, there has to be a way to kind of discuss it. But I keep bringing this up over and over again because I never want you to get pigeonholed into, well, they're only 64, so, I just don't want you guys as clinicians to get pigeonholed into following these to the letter of the law. Because again, my favorite, right, it depends. But for the complicated ones, over 65, greater than 4 per year, the 2 that we're going to want to focus on is using Augmentin. Another one that we would pick from would be fluoroquinolone. So these are lists of options versus you don't have to use them. It's not an and, it's an or. And those are really kind of what I'm going to focus on these lectures, or on this slide here. All right, so this is the last topic. This is that alpha-1 antitrypsin. It's kind of like that cystic fibrosis. It's like, if you have it, it's like, dang it, it sucks. It is also a genetic error. And basically what happens is that inflammatory cells, your immune response is inhibited with this condition. So the alpha-trypsin that's normally found in the blood I think I said that backwards. So it's alpha-trypsin deficiency that's normally present in the blood, so you have a decrease in the inhibition. So bottom line for this one is they usually end up presenting with emphysema earlier in life. So this is a patient that comes in, you know, typically a non-smoker. They're young, they're complaining of symptoms. They're having dyspnea. They feel like they're working hard to breathe. So they're presenting more with that pink puffer presentation, but instead of being 78 and a lifelong smoker, they're young. And again, similar to cystic fibrosis, for this one, there really isn't a cure. So we talked about lung transplant, we talked about other treatments, but for this one, there really is no cure. The key to these patients is really just, if they smoke, they're gonna accelerate that decline much faster. There's just some real quick additional considerations. Here's a differential. Asthma, cystic fibrosis is alpha-1. Kind of already talked about this one. COPD complications, the things that we're trying to avoid is that pulmonary congestion, the pulmonary hypertension, cor pulmonale, and then the exacerbations, the pneumonias. They're much more highly set up for that. And then the preventive steps, obviously, just getting to quit smoking, good luck. And then certainly we're going to want to make sure we vaccinate these patients. This is going to come into play a lot with a lot of the conditions we're going to talk about here on out, is this becomes very important to help minimize the impact of the disease. These are some considerations. These last couple slides are not ones that I would circle or highlight. These are just some additional considerations. We talked about when to refer, usually with that group E. If they're rapidly progressing. And we talked earlier, usually we let the SAT range of normal go down a little bit. Usually below 90, if they're just sitting there, consider referring. Maybe they're not being maximally treated. And then obviously admission. You have a patient come in, they're in an exacerbation. They're hypoxic. And we talked about hypoxia not really being dyspnea, it's more, hypoxia causes less cough and I feel short of breath, but more, I'm dizzy, I'm confused, I'm not acting normally, can't care for myself. And then certainly if they have comorbidities like cardiac issues. This is an FYI. Lung transplantation for COPD does occur. It doesn't have a horrible survival rate, but it's a pretty rough procedure to go through, and you know, getting a donor is not the easiest thing. And there was also procedures that where we actually reduced the lung volume. So I will skip the quiz today. Let you have your break before GI starts.
Miss Heather.
Huh?
Miss Heather.
Miss Heather will start with you guys. All right, thank you.